So today on the Ortho Perspective, we're joined by Dr. Manish Patel. Dr. Patel practices in Franklin, Virginia. He did a sports medicine fellowship at the Mississippi Sports Medicine and Orthopedic Center. And Dr. Patel is the creator of the Jiffy Knee, which is what I wanted to talk with him about today. So welcome, Dr. Patel.
Dude, thanks for having me. Really appreciate it and excited to be on your podcast.
Yeah, absolutely. So for anybody who's been on social media in the orthopedic world or patient wise needing a total knee, you've probably run across something Dr. Patel has created in the Jiffy Knee. And I personally had an opportunity a couple weeks ago to visit Dr. Patel and see him do 9 Jiffy Knees very efficiently in a day. I forget exactly what time we were done, but I was off to the airport in plenty of time for my 6 o'clock flight. So it was pretty efficient. So can you explain to the audience, kind of how the Jiffy Knee concept came about?
Sure. So I've actually been performing total knee replacements for the last 17 years, right out of my sports medicine fellowship. Uh, but the way I learned it was through a subvastus approach, but it was very challenging in terms of the exposure early on in my career. But over the years, I went to more of a medial oblique approach, going under the subvastus and the capsule. And I eventually got to a point where I was having great outcomes. Patients were doing well, but I was in a very small town, and so I wasn't getting the attention. So the patients that did well, they did fantastic, but I needed to do something to really distinguish myself with this modified subvastus medial oblique incision. And instead of just saying that to every single patient, this is what I do, I was like, well, let me brand it. And that's how, in end of 2018, I started the Jiffy Knee brand specifically to associate with this exposure to give it distinction compared to what most surgeons were performing in terms of the surgical exposure.
Yeah. And, what would you say as you're talking to physicians? And I know I had some misconceptions, but what are the popular misconceptions when you talk to someone who may have seen you on whatever social media platform? Just what are the misconceptions that they have when they talk to you?
Sure. I think the biggest one is that it is very difficult to get the surgical exposure. This technique of a subvastus exposure has been described for 40 plus years, and it's been tried before. The problem was that the surgical exposure was very challenging. And so I call my R&R technique, release and retraction, into step-by-step process to allow for that release of the release of the ligaments and the meniscus and things like that to allow for the exposure. So the surgical exposure was one of the biggest misconceptions, but every single surgeon that has come, they said the exposure is actually in some ways better than the traditional arthrotomy.
Yeah.
And the other one is that there's no difference between the subvastus approach, the medial oblique approach, and the standard arthrotomy. But imagine if you can do the exact same procedure, keeping all the principles same and keeping it agnostic to everything else, but you can preserve the soft tissues. So I call it minimally traumatic surgery, MTS, rather than minimally invasive surgery.
Yeah. And I can tell you from my personal experience, I don't know exactly what the BMIs were of the 9 cases you did the other week. They were not all skinny knees by any means. And that is one thing I noticed as well, because that was my misconception. But the knee was able, good visualization for me standing in the room, just like any other or better. So can you kind of, as you've implemented this, started marketing it for yourself, can you kind of give the audience your perspective on what this has done for your practice personally?
Sure. I truly believe in branding as part of the practice. And I think every surgeon to a certain degree has branded
Mhm.
themselves, be it their practice name or the approach or robotic or something. And so when I formed the Jiffy Knee brand in 2018, I went from performing about 80 or 100 total knees a year. And fast forward 4.5 years later, this year, first half of the year, I did 605 total knees. This year, I'm positioned to do about 1,200 total knees after the brand. And the brand is sort of giving me the notoriety for the surgical exposure, but the exposure and the outcomes and the data we're collecting is really allowing and driving what we're doing, because branding could be a double-edged sword, right?
Mhm.
If your outcomes are great, people want to associate with it, but if it's not, it can really hurt you. And I think we've gone definitely a positive route with the patient outcomes.
Yeah. So let's dig in a little deeper to that. Is the whole Jiffy Knee program is not just Dr. Patel. You're wanting to bring other surgeons along with this journey with you. So can you explain to us, to Dr. Smith out there who may be watching, what would this process look like for them if they're interested?
Sure. And I think and it's a great question. It's not just about the surgical exposure.
Mhm.
It's a complete experience of preoperative, perioperative, and postoperative experience and going beyond that. And so if there's a surgeon that's interested, first thing is they can contact me on LinkedIn, or they can call my office, going directly through the jiffyknee.com website. And the plan would be to do a 1 hour Zoom call where I would show them about the program, show them the data. We have data on over 2,000 patients to show how we have proof that this program works really well for patient outcomes and decreased narcotic usage and functional status at an earlier start. And then if they're interested, all they have to do is contact, once we connect, we would get them all to come down here. It's very simple process, no arduous paperwork to worry about. And the other interesting thing with this whole program is they get to scrub in. You saw the surgeon actually
Yep.
scrub in, the one you came with. And he or she is going to be able to actually learn the tensioning, the releasing, and really get their hands into the field through all the 9 cases if they want to do that. And then afterwards, they can decide and they can go back and practice their surgical exposure. If they want to be branded as a Jiffy Knee surgeon, we can allow them to do that. We can go into specifics when they come for that. And this will allow them to do that. And with the Jiffy Knee brand comes a whole new terms of exposure with social media and digital marketing through LinkedIn and as well through Facebook and Instagram to get them the distinction that they would need.
Right. And as you mentioned before, I mean, branding is extremely important. I've been in the industry about 30 years, where I remember times where even doctors advertising in their community was kind of controversial. But
Yeah.
there's no doubt about it, with social media, just everything's happening, is whether you like it or not, that is important for surgeons going forward. Um,
Yeah.
and so it is interesting to me, and I'm fascinated just by your number growth, and even hearing you. I mean, just the effort that you are putting behind people that would sign up with you is truly unique. And then
Yeah.
to Yeah, go ahead.
No, I was going to say the surgeons that have joined the Jiffy Knee program, they've all at least had a minimum of 100% increase in their surgical volume when they became Jiffy Knee surgeons. Some of them are 200 to 300% their growth just in the last 3 to 6 months.
Yeah, I mean, that is amazing. And the other thing that you mentioned that I did want to highlight was you did 9 cases, and you even suggested, hey, scrub in on the first few, do it. Then we'll get you a clipboard. You can take notes, which I didn't think about it, but you have created this learning experience for them where they can see some, step back, watch some, and then come back in and scrub a few more with you to really understand, the nuances of the technique that you're doing.
Yeah, and I think that's very important. And it's very reproducible. That's the other amazing part. It's not as intimidating, which can be going from a posterior approach to a direct anterior approach where the
Mhm.
anatomy is completely different. The anatomy with this approach is very easy. So the exposure can be reproducible afterwards. And it's just all about placing the retractors in the right moment at the right time and understanding the tension. And that's what we're trying to focus with the surgeons coming, that this is actually very straightforward.
Yeah. Well, so why don't we talk about the future a little bit of the program that you're creating? Is what is your vision for the Jiffy Knee program? You've touched on it and people could understand a little bit, but 2 to 5 years from now, what do you see this looking like?
Well, I want to try to change the landscape of how we perform total knee replacements. We've made significant improvements in the cement, the implants, the polyethylene, robotic surgery, so many different concepts that we've improved. But the one thing we actually have not changed in the total knee replacement is soft tissue preservation. And so my hopes is that we can try to push this to say, hey, this is going to be somewhat of a standard that patients will be requesting. And if we can do that safely with the data. And so my goal is to add as many Jiffy Knee surgeons and then start collecting data on their patients as well to be able to create a larger data pool of patients and eventually make it so that when patients come in, they're able to get the benefit of this soft tissue preservation technique and can try to go towards that route of what direct anterior did to the posterior approach for the hip replacement.
Yeah, that's interesting that you say that, because the surgeon that I accompanied down there, his exact analogy was he views this as kind of like the anterior, what anterior hip did for the on the hip side. He sees this could do that on the knee side. You mentioned robotics. Is the Jiffy Knee, I'll just say, compatible with assistive technology such as robotics navigation?
Yes, it's very much compatible. I actually did about 14 robotic surgeries. And what's interesting is most of the rays and all in the robotic program, those pins have to be placed onto the distal femur and the proximal tibia and on the intramedial aspect of the distal femur. So all the soft tissues, including the VMO and the quadriceps and everything, is actually pushed out to the lateral side. So interestingly enough, it's actually easier to place those pins on the distal femur on the medial side without having to worry about the pin toggling, because half of your quadriceps tendon is still on the medial side with the standard arthrotomy. So actually can work for robotic surgery and augment it easily.
Yeah, which is obviously a lot of people listening, that would be good for them to hear, is they're not having to get away from something that they may really enjoy using. So,
Sure.
Dr. Patel, I really appreciate you taking a few minutes out of your day to talk with me today. If there is a surgeon who's interested in learning more about the Jiffy Knee, just tell them the best way again to contact you.
The best way is they can contact me directly through LinkedIn, look me up and they can do that, or just go to jiffyknee.com and they'll find the office phone number and they can just leave a message with my office manager that they're interested and she will get me the information. And Stu, I really appreciate you having me on your podcast, and it's definitely a privilege.
Absolutely. I appreciate you. And it was extremely enjoyable for me a couple weeks ago to come down, not only meet you, but to see a little bit of what I had seen on LinkedIn as well. So I thank you. So Dr. Patel, thank you and have a great rest of your day.
Thank you, and you too.